Good morning, ladies and gentlemen. Welcome to another episode of Monitor Your Health, the program where we educate the public on contemporary medical situations. My name remains Dr. Femi Ogunremi. I will be the host for today, and we'll be discussing stroke. Stroke is very important, and we know that it is the second most frequent cause of death globally, based on statistics in 2011. About 6.3 million people actually died from stroke in 2015. And looking at developing countries, we notice that the prevalence of stroke, that's the rates at which we have, the number of stroke that we have in communities, especially in developed country, is reducing by about 10% over past few years. However, in developing countries, this rate has been going at, have been increasing at the rate of about 10% as well. In Nigeria on its own, we have about 100,000 people suffer from this, condition. And the percentage of people that would die from this is about 40%, despite the inadequacy of the data that we have in this part of the world. In order for us to discuss this today, I have with me Dr. Olaleye, a neurologist, who will be anchoring and answering questions for us today. You're very much welcome, Dr. Olaleye.
Thank you very much, Femi. I hope I can call you that.
Sure. Thank you.
It's a pleasure being on the program, and I greet our viewers at home and all the people subscribing on YouTube to this channel. Thanks so much.
Thank you. Please, can you introduce yourself, to the audience?
Yes. My name's Dr. Olaleye Adeniji. I'm a neurologist. I work as a consultant neurologist at the Federal Medical Center, Beokuta. That's where I work. Again, I've been involved in the care of stroke patients in the last 6, 7, 8 years. So I feel uniquely privileged to comment and participate in the show. Once again, thank you for having me.
Thank you so much for that. So if we go into it, what do we mean by stroke? What stroke?
Thank you once again. A stroke is a condition or a situation in which the blood supply to the brain is cut off. That's the simplest way you can think of it. The way God made our brain, there are these pipes or arteries that carry blood to the brain. And if for any reason the blood supply to any part of the brain is cut off, it's a stroke. Why is blood supply so important to the brain? Blood is the life force of every organ of the body. So the blood carries oxygen, it carries glucose, that is the nutrients the brain requires to function. As we are talking now, our brains are functioning, coordinating our speech, and I'm sure the viewers at home are listening to me too. Their brains are coordinating their ears and their eyes. If for any reason that blood flow is cut off, then that is a stroke. The more technical definition is a focal neurologic dysfunction or a focal neurologic disorder due to abrupt ischemia. Ischemia just means a lack of blood to the brain or to the spinal cord or to the eye. So 3 organs there. If there is cut off of blood to the brain or to the spinal cord or to the eye, then it's a stroke. And it follows from that definition that stroke not only affects the brain, even though the brain is the commonest organ, it can also affect the spinal cord, which is not quite common, or it can affect the eye. Can have a stroke, just limited to the eye. To round up that question, the commonest condition, let me put it that way, that predisposes, or the 2 common types of stroke, let me put it that way. There's one we call an ischemic stroke, which means the arteries carrying the blood to the brain, they become blocked. And there are multiple mechanisms whereby they can become blocked. And the second one is called an hemorrhage, an hemorrhagic stroke, which essentially means the arteries tears. In other words, if you think of it like a pipe in the house, the pipe has a leak. And either way, both of them result in the same thing. Blood flow to that part of the brain becomes compromised. So that is a simple way to conceptualize the idea of a stroke. It's acute, it's sudden, it results in blood being cut off to a certain part of the brain, and it has multiple downstream effects on the patient and the individual. Thank you.
Thank you so much for that. So we now know that a stroke is a situation where there's a cut, a kind of an abrupt, cut off of blood supply to the brain. Now,
yes, you're right.
Yes. So what are the signs? What are the things that we see when we say a stroke at the core? What are the things that people will see? What are the symptoms and signs?
Yes, thank you. Thank you very much for that question. By far, the commonest symptoms that are seen are being conceptualized in an acronym called FAST, F-A-S-T. Of course, it's by no means prescriptive, but those are the commonest symptoms you see. The F stands for face. So people who have stroke often notice immediately after the stroke, I'm talking within minutes now, that their faces become asymmetric, or there's a weakness on one half of the face compared to the other half. So as we are talking, as I'm looking at you, your face is symmetrical, your lips are on one even horizontal line. People with stroke often notice, or their relatives notice, that one half of the face is higher or lower than the other, what we call facial asymmetry. That is one. The A stands for arm weakness. Right. Oftentimes, they have problems with power in their arms or in their legs. So they may complain of being unable to lift the arm or lift the leg. Or they may not even be able to complain. It will be the relatives who will notice that the patient is unable to move the arm or the legs. And the S stands for speech. In the more clinically overt strokes, speech is often affected. So patients have problems talking. The speech can be slurred, it may be difficult to comprehend what they are saying, or they begin to sound like somebody who is drunk, somebody who is speaking clearly. Suddenly you notice the speech becomes slurred. You are finding it difficult to hear what they have to say. And those are the three common signs we see in stroke. The T in FAST stands for time. And that's just to remind us that once you see any of those three, you need to act fast, because it tells you that a stroke is actually occurring at that time. So F-A-S-T, face, arm, speech, and time. But having said that, stroke can present in multiple ways. Remember, I told you that it's not only the brain that is affected by a stroke. Sometimes, although it's not very common, strokes can involve the spinal cord, in which case patients can present with inability to move the arm or the legs alone. But there may not be problems with speech. Or it might affect the eye. So sometimes patients might present with what we call sudden blindness. Sudden blindness. They just complain that they can't see suddenly because the artery supplying that eye has had a cutoff of blood supply. So that is on one side. And the kind of strokes that present like that and cause symptoms, you could classify them as the majority of strokes, maybe 60, 70% of strokes. But there is a whole gray zone, and I use that word advisedly, gray zone of strokes that may not present with overt clinical signs, what we call silent strokes. And these are commoner in the older age group, people over 60, over 70. And what will be noticed is that the patient begins to deteriorate cognitively. In other words, memory becomes a problem, personality changes, problems with controlling urine, controlling feces, problems with moving and walking about, the family members will know that the patient is changing, but they wouldn't be able to put their finger on it, what exactly it is. So that again, but it's called a silent stroke because by the time the patient is presenting with all those a small
All right, so I think we lost Dr. Olaleye there. So he's coming back now. Okay, hello. Okay, so he's joining us now. So we're talking about stroke, and then I think he's been talking about, the symptoms of stroke. One way or the other, the internet has been epileptic. It's always, it seems to have become a common thing in Nigeria these days. How the network providers here and there will be able to, do some justice today. So we're talking about stroke, and he's been talking about the signs and symptoms of stroke. So we're talking about, what can happen. Is been talking about the silent stroke, whereby individual presents with things not particularly, typical about the fast, symptoms. He already told us. Sorry, let me try and add him on. He's trying to. So there are certain things that people can present with, like memory loss, cognitive, or they might have issues with
yes.
Okay, sorry. Yeah, that's fine. Carry on, sir.
So I think I'll switch up my video. I think that if it's prolonged, it interferes with the network. So hopefully we shouldn't have that problem. So as I was saying, can you hear me now?
Yeah, we can hear you. So it'd probably be better you put a picture on because it looks black. If there's a picture, you can put it on. Otherwise, it's just showing your name alone. That's fine. Okay. Okay. Are you there? Okay. Sorry. Well, you're muted.
Clinically obvious strokes.
Yeah.
Which present with facial weakness, arm weakness, speech problems, or the silent strokes. So I think that suffices for that question.
All right, thank you so much. So now we know the symptoms. We know that there are some atypical symptoms people can present with, which are not classical, as we talked about memory loss and other functionalities. What are the causes? What are the causes? Oh no, sorry. What are the causes or the associated things that the public need to be mindful when we're talking about about stroke?
Yes. I rarely give categorical answers to questions, but in this case, I'm going to give a categorical answer. In this environment in Africa, Nigeria inclusive, the commonest identifiable risk factor for stroke is hypertension. It is hypertension. The risk that people with untreated hypertension would end up in stroke in this environment is very high. In some studies, as high as 90%. So that is the major risk factor for stroke in Nigeria today. It's the major risk factor even in Africa. Having said that, in medicine, we often talk of modifiable and non-modifiable risk factors. In other words, the things that can cause a disease that we can modify and the things that we are not able to modify. So the modifiable risk factors, diseases like hypertension, again, diabetes, which is also common in this environment, renal problems, renal failure, strokes occur in renal failure, sedentary lifestyle, people who don't exercise enough, diets high in fats, in processed foods, in refined sugar, has been noted to be associated with strokes. In people who have a family history, and that's a non-modifiable risk factor. If there's a family history of stroke, especially in a first-degree relative, maybe a father or a mother or a sibling, a blood relative, it increases the risk of stroke. Age. We know that stroke increases as you go over 60. The risk of stroke increases exponentially. Of course, because it has to do with the way the arteries become stiff, they calcify, they become blocked as we grow older. So that's another risk factor. Being a man, being male, is another modifiable risk factor. So if you're a man and an African man, then you are more at risk. And the other risk factor is tied to it being African, because we know, like you said in your introduction, that Africans have a higher rate of stroke compared to the Western world. Indeed, in much of the West now, stroke rates are declining. But for yet unexplained reasons, which is, I think, is tied to control of hypertension majorly, stroke rates are climbing steadily in Africa. And right now, strokes are the commonest neurological disorder we see in our hospitals all over the country. So it tells you the idea of the problem. So that, in a nutshell, summarizes the. There are other risk factors like alcohol intake. People consume alcohol, smoking, use of recreational drugs like cocaine, marijuana, Indian hemp. These ones have also been associated with the risk of stroke. In people who are obese, if you are on the big side, your risk of stroke may also increase. So these are some of the risk factors.
Oh, sorry, carry on.
Yes, I hope you could catch the last part about obesity.
Yeah, okay, that's fine. So
yes. Obesity too. So those are some of the risk factors that are associated. But by and large, hypertension is the major driver of the stroke epidemic we are currently experiencing in Africa.
Thank you so much for that. So now, when we look at obviously the causes, we've looked at things that we can modify, that we have control over ourselves, and we have things that we don't have control over. I don't have control over the fact that I'm a man and I'm a black man as well. That increases our risks. And then, but things like the food we eat, exercise, smoking, alcohol, and all this business, we have control over. I hope the public are picking this. A lot of young age group able men in Nigeria these days drink a lot of alcohol in excess. It's amazing when you go out every evening, not even weekend, every evening you see people just sit down drinking and eating all these red meat, things like that. It's a common thing, and I think it's something that it creates a kind of alarm in my ear when I just see all these things going on. So our people, our men, our ladies, it's important for us to keep an eye on this, like we've been told by our experts today. Thank you so much. So now, if a stroke had occurred, some people will sit down there and I'll be saying, oh, I think my memory, I'm not sure, I've been losing memory these days. They're very stressed out with a lot of things going on in Nigeria as well. And they'll be thinking, hey, is it stroke? What are the things or how do we diagnose stroke on the basis? What are these people, or what do they need to do if they think they have symptoms or signs of stroke?
Yes, thank you very much. I spoke earlier about FAST, and the T in FAST stands for time. If you suspect that you have a stroke, you should come to the nearest health facility. You should see your doctor immediately that day, not tomorrow. That day, you should see your doctor to have yourself checked out. And your doctor will want to know your history. Do you have any medical condition? Do you have hypertension? Do you have diabetes? because if you have all these things, that it increases the risk of stroke, especially if it's not well controlled. So the single best advice we could give is, if you suspect that you have a stroke, then you should present yourself to the nearest available health facility to be seen by a competent doctor who will be able to decide and whether you need referral, whether you need to be put on the stroke investigation pathway. So that's the best initial advice.
Thank you. Yeah. Now, I'm going to just touch on this. This is from my own personal experience. Okay, so in Nigeria, I've had a few cases where people call and they said, oh, they have a stroke, or, there's issue, they're being suspected to have a stroke and they're on some treatment or the other. And I know from my own training in the UK, if I think about a stroke or we think about stroke, it's important for us to know, just like you said earlier on, is it a dry stroke or is it a wet stroke, hemorrhagic or ischemic stroke? And I believe, if I'm right, that the only way you probably pick that is by you having a CT scan, which will look inside the brain and be able to tell us within this space, as we talk about time, because time is of the essence. The brain, the cells of the brain keeps dying each time nothing is done. So these people are seated there and they said they have a stroke. In some cases, they start treatment. And then I then ask, what is the CT scan report? I think this is more to our colleague than the public. What is the result of the CT scan? And people can't tell me the result of CT scan because either they've not done the CT scan or they've done the CT scan and the CT scan is sitting down somewhere waiting for somebody to report it. And we talk about time. Are we really serious about this? Or are we just joking?
Well, you've raised some very, very relevant points, which would also follow from my response about stroke investigation pathway. All over the world, there is a standard way to approach stroke. If a patient comes in and says, I think I have a stroke, or if the relatives come in and say, we think our relative has a stroke, there's a standard way to approach it. And almost all the guidelines agree that the best initial investigation of choice is a brain scan, a brain computerized tomography scan, a brain CT scan, which, like you said, will help us to differentiate on the type of stroke we are dealing with, whether it's an ischemic stroke or an hemorrhagic stroke. The reason why it is so important is because if it's an ischemic stroke, medicine is so advanced now that there are treatments we can give if the patient is presenting within the first 4.5 hours, what we call thrombolysis. And that can be given. Even in Nigeria here, it can be given if the patient presents within that time window. But the key to making that decision is to do a brain scan. And that's why I said if anybody suspects a stroke, you should get to your health facility immediately. You remember I used that word immediately, not tomorrow, not the day after. You should, because the doctor will decide whether you then need to go to do a CT scan or not. Now, we have challenges in Nigeria about the distribution of CT scans, the cost of CT scans. A CT scan at international rates costs about between $80 and $100. That's about between 40 and 50,000 naira, depending on where in the country you are. So, and the patient and the relatives have to bring this money out within 4.5 hours. It has to be done. So, and you can imagine how many people are liquid enough in the economy of today, especially if you realize that strokes seem to affect more people in the lower socioeconomic class. I hope you are hearing me.
Yeah, very loud and clear. Thank you.
Strokes, oftentimes what we see in the hospitals is the people of the lower socioeconomic class, the artisans, the market women, and these are people who live on a subsistence basis. So how do you get this kind of treatment to them within the constraints of the time window? If it's an ischemic stroke, you would now be talking, okay, does it meet the time window? Is this somebody I can get a thrombolysis for? It is another hurdle, because we know the cost of thrombolysis in Nigeria today, anything from between $600 to $1,000 US dollars. So which would translate to between 300,000 to up to 500,000 naira, and it has to be done within 4.5 hours. So you begin to see the nuances of where the problem is. the spread of the investigation materials, the scope, the costs, then the knowledge about stroke. How many people are aware and are able to take that decision? Because once the clock starts ticking, then really you have just 4.5 hours. That's all you have.
So
if any definitive intervention is to be given.
It's going to be done. Yeah. Can we then look at, because that leads me to my next question, which would be like your own view and advice to the government. Because if we're really serious about managing, the stroke, I know Nigeria is a peculiar country and things are happening in our country, which is really sad. We don't have emergency system. We literally have nothing on ground. As far as I'm concerned, people like yourself, like myself, and other people who are doing our job here and there, we're trying our best. But are we really hitting the right chord? Will be the main question, because we're talking about stroke being the second most frequently, most frequent cause of death. It's as serious and significant as it stands. The rate of it is increasing in our society. And then we know that the kind of society we have artisans, we have all these people who cannot actually, pay for, out-pocket payments. But our government isn't doing anything as far as I'm concerned. Wow, nothing is being done when we look at stroke, because in a situation where we ask people fast, we're shouting it now, go to the hospital. Do we really have the resources to handle this? Because if we know our problem, then we can solve our situation. If we think that the artisans or people who are involved in these things, they can't pay, can we be looking at a way of, helping to subsidize or way of doing things? I know that there will be a lot of things to talk about this, but I want to know what your views are, or what you want to advise the government on how we can actually seriously and sincerely impact the life of people who suffer stroke in this country. Because I think we are just joking. We're just doing as usual. We talk, and no action, as far as I'm concerned. Because a lot of people are still they're dying from this. Doctors are doing the wrong things. A lot of doctors are doing the wrong things. When people come to you, a neurologist, you know what you're doing. I hear some cases, I will almost cry, because somebody will sit in a place, we're talking about 4 hours, they've come within the window, they sit down there, the doctors do not even know what he's doing. That's the truth. In the private hospitals, people sit down there, they just ask you, they know that the people are seriously sick, people take this as an advantage. Very unethical practice happen in Nigeria. What is your advice? What is your view?
Well, you've done an excellent job of dissecting the problem, I must say. But again, the solutions have to come from the problem. There's no one size fits all solution. If you look at the way the country is structured, the basic, and I think a lot of the criticisms you raised even also applies to other diseases, not only stroke. People have heart attacks, what we call ischemic heart disease, coronary syndromes. People have emergency presentations of renal failure. People present in heart failure, they need urgent care. So it's really about the way our health system is structured. Problems of access, especially physical access and financial access. Physical access in the sense that we don't have the hospitals enough in the numbers that we need, and government alone cannot fund them. Financial access in the sense that, yes, we have a national health insurance, but what percentage of the population are covered indeed by the national health insurance? As of today, I don't think it's up to 20%. I may be wrong, but I don't think it's up to 20%. So at the government level, we have to think of how do we increase access, both physical and financial. We need more hospitals, and we need more people who are able to be financially supported to access care. And that does not speak to stroke alone. Having said that, on the personnel side, we need more training, capacity building, so that people may understand what to do when we talk of stroke. The local government primary healthcare system is the closest to the people. The way our health system is structured is the closest to the people. But if you go to most of the primary healthcare centers, sometimes you may not even find a doctor there. You find nurses sometimes if you are lucky, or you find CHUs, community health extension workers. And if you ask those community health extension workers their knowledge of stroke, and studies have been done about this, the knowledge of stroke among them is low. It's very low. So, and again, these are the people who initiate, even if you get to the teaching hospital, these are the people who start the initiation of treatment. So we need more capacity building. At this point, in an ideal world, every patient will come to the teaching hospital with stroke, and every patient will be seen by a neurologist. But we know that is not the reality. We don't have enough number of neurologists to treat strokes in this country. I don't think we have up to 200 neurologists as we speak right now. The few ones we have, a lot have left the country. So, I mean, it would be unrealistic to expect. And you yourself said it, that 100,000 people have had stroke in Nigeria. So it would be unrealistic to expect that less than 200 neurologists will face 100,000 people, or a potential stroke population of almost 150 million people. So you begin to see where the problem is. We need more staff at the middle and lower level, more nurses, more stroke nurses, more stroke physiotherapists, more stroke pharmacists. We need more community health extension workers who are aware about stroke.
Exactly.
Essentially, we need what is called task shifting. That's the word. And if you go on the WHO website, a lot has been written about task shifting, not only for stroke, because we don't have the requisite number of personnel to handle strokes. Then, having said that, we need more government involvement, more government expenditure. If you go to most of our teaching hospitals, you see that their CTs or their MRIs have problems. If they are not breaking down today, they'll break down tomorrow. In fact, studies have shown in Nigeria that the bulk of the machines we have for CTs are in private hands. Most of the CTs are owned by private companies. And I'm sure you know, in Lagos, in Ibadan, in Abuja, in Port Harcourt, it's mostly private. And the private are set up to make profits. So government still needs to come in, because the private is not going to waive their money. So, and the question of logistics, how do we prioritize strokes? And I'm aware there are so many initiatives ongoing. We have an African Stroke Organization that's just been established, comprising of like-minded professionals who are interested in stroke. Their website will soon be coming on stream. So we need more capacity building, more participation. Then, more importantly, we need a standard approach to prevention. Because let's think about it, stroke is preventable. That's the sad irony of all this. And that's why I must commend you for this program that you are doing. Because by disseminating the information out there, you are putting it out there so that people can take personal responsibility for their health. Up to 90% of strokes we have in Africa is completely preventable. So we need regular surveillance of risk factors, epidemiologic surveillance of risk factors. What is the proportion of people with hypertension? What are the barriers to effective treatment of hypertension in this country? If we treat hypertension, if we treat up to 90% of people with hypertension in this country, the prevalence of stroke will fall by more than 60%. And this is studies. It will fall by 60%. So we'll spend less on bringing in expensive machines. And I think prevention and treatment of hypertension is something that should be done universally, not only in the teaching hospitals, even in the primary healthcare centers, the private hospitals. Everybody in the healthcare chain should have sufficient knowledge on how to prevent, how to treat, how to counsel on lifestyle changes. So, because that's our only realistic hope. Yes, we will have those centers that will treat and thrombolize, but in the long run, when you look at it on an economy of scale, it is still prevention, prevention, prevention. Thank you.
Thank you so much. I think you've said a lot there, and there are some areas I really want to even touch on, but because of the time, we might not be able to touch on them. I will just bullet a few, and I know that we can continue the engagement from here, because you said it, capacity building is the main thing. And I know that when we have our problems, the headache I have is I practice in England and I practice here. And I realized, I see the way we do things in Nigeria. I see that we want to copy word for word, or just like that, as they're doing things abroad and want to bring it home. We're not looking at our own problem as a unique problem and look for a solution our own ways. For instance, we talk about CHUs. CHUs are doing a lot here. In my village, we have a small community primary health. care center. There's only one. All right, sorry, I went off there briefly. So it is in a situation where we need to start thinking like this is our situation, and this is the way for us to handle it. That we look at possibly empowering these people heftily for them to be able to manage things reasonably to get patients to the center where they can actually be managed. You understand? I know that, when I don't know the acronym you used earlier on, a situation where we have to think about, having like stroke nurses, have a stroke, practitioners. It happens in the UK where I practice. I know that we have. Okay, sorry, the internet is quite epileptic. It's just kicking me in and out. So I think we're just rounding up now anyway. Obviously, I think, we need to look at our situation. I'm talking to you today, Dr. Olaleye, because I know you are very, high there when we talk about stroke management in the country. And I know the association that you are part of. And I think we should be looking at things, looking at our own problem and how we sort it out. We shouldn't, I know that a lot of people I've spoken to where they talk about, oh, yeah, look at your patients, look at their lives. I think that's what we need our fear. And then not thinking there's so many quacks in Nigeria. Train them properly and let them do the right thing. That's what I think. Round up this this session as we have gone a little bit above our time now. You're muted.
You hear me now?
Yes, I can hear you now.
I completely agree with you. The more people we have on board, the better. And I think voices like yours will also be needed in the crusade. It's not something a single man can do. It's not something, but we have experience. If you look at, for example, I cite the example of maternal mortality in Nigeria. There was a time maternal mortality was such an issue. Nigeria had perhaps the highest rate in the world. But we had government being sensitized. You had foreign agencies coming in. You had everybody coming in, from nurses to doctors, even to traditional birth attendants, spiritual homes, pastors, imams, babalawos. Everybody came in, and slowly but surely you had the rate coming down. So we need a public health approach, really, to managing stroke. The same way we approach HIV, for instance. I think it's getting to that level that we need that approach too. So I must commend you for bringing up this initiative and all the wonderful and excellent suggestions you have put forward. I hope our viewers at home too will take this and run with it, because we don't know their circle of influence. So that the more we spread the message, the better it will be for everybody. Once again, thank you for having me, and thank you to our listeners at home as well.
Thank you so much, Dr. Olaleye. It's been a nice session with you. And to the public, I really appreciate you. Without you, there's no program. And we hope you've learned something from here today. We said a lot of things here with the hope that there are people of influence out there who might be able to take things and take it forward. The bottom line is patient is at the center of our best for our patients. So, all right.